I would like to thank Dr. Sparias for this kind invitation, and would like to introduce you the heart team of our center, of Onassis Cardiac Surgery Center. Dr. Iakovou, Dr. Leodiadis, Dr. Stavridis, our cardiac surgery director, Dr. Tsoukalas, and me. So we're going to start with heart in case, a very young male, 46-year-old with gradually worsening airport dyspnea and high NT-proBNP. Our diagnosis here is severe symptomatic mitral regurgitation. Our patient suffered an inferior STEMI back in November of 2023 with cardiogenic shock, and his coronary angiogram revealed severe coronary artery disease. In another hospital, his physician there decided that the culprit lesion was the right coronary artery, so they performed PCI in the right coronary artery with the intra-aortic balloon support. 1 week later, the heart team of the other hospital decided that the full revascularization for the full revascularization had to perform CABG, triple CABG, and ambioplasty with complete semi-rigid ring stimulus 30 millimeter due to moderate MR. But no reduction annuloplasty was performed despite MV annulus at about 36 millimeter. Here you can see the pre-procedural echo moderate ischemic MR type 3B carpet Jens classification, posterior leaflet tethering due to aneurysmatic posterior and inferior wall, moderate LV function, and MV annulus about 36 millimeter. And then the post-procedural transesophageal echo depict a mild to moderate MR. Then the patient undergone defibrillator implantation. He has also arterial hypertension, dyslipidemia, pulmonary hypertension, and COPD. And here you can see the surgical risk scores. So from the screening coro, we have an obstruction of RIMA, but the scintigraphy depicted the absence of ischemia and RCA scar. Here you can see the right heart catheterization and the screening echocardiography assessment for this patient. We have a moderate LV function and a large LV, severe secondary MR, posterior leaflet tethering, anterior captation with holosystolic flow reserve in pulmonary veins and pulmonary hypertension. Here you can see some images from the screening transthoracic echo. You can see here the posterior tethering, the large anterior leaflet, and the severe mitral regurgitation. We continue with more pictures. You can see in the left down picture that the anterior leaflet is a little bit about 20 millimeters, and then you can see some images from the transesophageal echo that also shows severe regurgitation of the mitral ring. Also here. And then to move on, we have some images from the 3D assessment. So this is an FMR patient, prior mitral annular ring placed. Calcium can be observed in the grasping zone, and coaptation gap due to progression of the disease is about 10 millimeter. This would not be a suitable candidate from a TEER, so we have to find another solution. Here we see some images from the valve application. Yeah.
On that, Vangeli, do you have any comments on the echo and the line of thoughts that we had? And maybe Dr. Sparias can make a comment, and Theo as well, if you can comment. Would you clip this case? Kostas? And
with LVOT obstruction, then that would be something to attempt. But here you're lucky, the patient not so, because the left ventricle is dilated, sizes are large, and there'll be no problem with LVOT obstruction if you go for a valve. So it'll be a more straightforward procedure to go for a valve. You'll eliminate the regurgitation and with no risk of LVOT obstruction. And so I think I will go this way. So if there was LVOT obstruction, then it can be attempted, okay. I think.
So if you have a big ventricle, that you would approach like that. This is your default approach as well, Theo, right?
I agree with Kostas, but the anterior leaflet still, when we look at the anterior leaflet, it's still long, but I agree with that there seems no risk of LVOT obstruction. But in any case, I think you will take a CT maybe to measure the neo-LVOT. And also another important thing is this secured neo-LVOT is also very, very important for selection of the type of the balloon expandable valve also.
Okay, so would you change your approach according to the new scared?
For example,
so would you use a MI valve as opposed
not
to
in particular
Edwards?
This case?
Yes.
But if for example, anterior leaflet is long and skirt neo-LVOT is also low, we had to do some leaflet modification like lampoon or anterior balloon atrial translocation of leaflet Batman procedure. And also if the skirt neo-LVOT is not good, even if the anterior mitral leaflet is adequate for the valve ring application, I prefer to use MyVol instead of Edwards because of the selection of the intermediate size and also the 6 millimeter larger area of the distal part.
So this is good to know, Vangelis. So you have.
I would like, Kostas, thank you very much for the kind invitation once again. I would just like to make a comment on this is a 40-year-old patient, so the question is, do you really want to abolish the mitral regurgitation? Because this could be risky for the ventricle and for the operation. So our first thought was to do edge-to-edge therapy, but it's a very big gap. The posterior leaflet was tethered under tension, so we thought that we had practically very few chances to make a successful treatment with edge-to-edge. So this is why we talked over it in the heart team, and we went through what Elias just showed.
And also maybe we can have a comment by Dr. Stavridis, who is online, and who help us understand what kind of surgical procedure was performed before. So, George, can you hear us? Can you make a comment?
Yes, can you hear me?
Yes.
Yes, hello. Good evening, everybody. I think that it was very brave for the surgeon the first time to spend some time doing arterial grafts. And of course, I agree with you. We knew that his chances of sealing this valve would have been impossible with a repair. So ideally, the valve should have been replaced. But of course, I don't know what the outcome would have been. So it's in case he had done the very successful bypasses, as you saw, because all the grafts are patent. And in case he had replaced the valve, now probably you would have a patient with non-leaking valve, but I don't know whether he would have been alive.
So, to proceed, now we have proceed to screening CT. You see here that high risk for LVT obstruction is that neo-LVOT area less than 2,000 square millimeters, and the arterial MV leaflet more than 2 centimeters. here from the, if you can see here, the neo-LVOT area is about 534 square millimeters, so we have no worries about that. But there are some concerns about the length of the anterior mitral leaflet. So the heart team of our center decided that the transeptal TMVI valve in ring with balloon expandable valves should be the optimal strategy. And I'm going to show you some video from inside the procedure. Right femoral vein, other ultrasound guidance, right radial artery pigtail, 5 French aortic root, transeptal with, and we advanced a wire ablet super stiff to left upper pulmonary vein, Achilles catheter, we advanced wire Safari small and Safari extra small as body wire, atrial septal dilatation with a balloon Atlas Gold, and an implantation of Edwards Sabin Resilia, 29 other rapid pacing via pacemaker wire. And now you can see some video from inside the intervention. Here we can see the assessment before the procedure here. I'm going to skip them. We have some measurements from the leaflets about 2 centimeters or less. So we are going to puncture the right femoral vein here under ultrasound guidance. Here. We put a prostyle system. These pictures are from our novel recording system with multimodulatory. Okay, and then here you can see we advance the amplat super stiff wire to the left upper pulmonary vein, and after the transeptal. And here is the Safari wire, small and extra small as a body wire, as you can see here. We put the pacemaker wire, and then we proceed with the atrial septal dilatation with Atlas Gold balloon. The preparation of the valve here, bird's eye view, and
yes, Dr. Kilitz, please.
There are very good examples of here the usage of the body wire technique. This is very important for the support of the valve, and the usage of Atlas balloon, because when we dilate the septum, it often behaves recoil. So that body wire also will be helpful. Just another inflation before the valve insertion, because when you first dilate the septum and it recoils, and then you prepare the valve and you insert the valve, and the valve cannot pass through the septum. This is another problem. In these cases, I usually prefer, for example, for the body wire technique, use a 7 French multi-catheter by inserting to the first position and put the stiff wires inside that multi-catheter. So it's another helpful maneuver.
So you use a 7 French multi-purpose
Yes.
catheter. Yeah. So it's not available here, but I don't know. Costa, do you use a multi-purpose 7 French to have the 2 wires in place?
No. We just pre-dilate the septum with a 12 or 14 millimeter balloon, and we never had a problem to go through. I've seen cases, Dr. Kiltz mentioned, I've seen cases presented in meetings that they couldn't advance the valve. But it's not something universal to use a body wire. In the old days, I was using a Lanterquist always to do these cases. But nowadays, I also go with a Safari extra small.
Just use a peripheral balloon.
Yeah, a peripheral balloon. I don't think it really matters.
Balloon. Okay, good. So, Ilya, you can proceed.
Here we're ready for the valve implantation. The first step is the rapid pacing. And here you can see the rapid pacing, and we start the implantation here. We have to be at about 15% at the atrial side and the rest in the ventricular side.
I think you put an extra amount of contrast to the 29 millimeter valve. How much?
I think it's 29 plus 1.
29 plus
Plus
1.
yeah.
Difficulty in valve and ring is that you have to be very precise in the positioning, so that you put the skirted part of the valve at the ring. Because if you're even at one point lower and then the non-skirted part goes below the ring, atrial to the ring, then you get a lot of regurgitation, and you have to go with the second valve. On the other hand, if you are too ventricular, you may miss a point at the ring, and then there might be a risk of malpositioning and moving ventricular.
Exactly.
Here you're just okay. You see at the upper part you're fine. You see the waist, but at the lower part you see that you are very borderline, but you are still okay.
Exactly. So we were ready for a second valve. But yes, you can proceed. So we were debating, but we didn't see, we thought the result was acceptable. Elias, you can proceed.
So we have here pigtail in order to measure the peak-to-peak gradient. We have no gradient around the valve, so we have our echo assessment. No significant MR here, but I will skip this. Here is our 3D assessment. So now it's the time that our anesthesiologist says that the patient needs more and more inotropic and vasopressor support. So we are starting to think about to plant an intra-aortic balloon. And here you see that we punctured the left femoral artery, and we place an intra-aortic balloon. I think you can see somewhere here. Okay, and to move on, we have post-procedural excellent result, no residual MAR, absence of peak-to-peak gradient, but we implanted an intra-aortic balloon and vasoconstrictive agents. The left ventricular ejection fraction decreased to 25%. Progressive elevation of lactate levels, no sustained AVT episodes, low blood pressure, and at about a couple of hours later, an ECMO insertion. I want to be quick. I have a plan here from the patient. ECMO removal 1st of April, intra-aortic balloon removal, discontinuation of inotropic and vasopressor support, and improvement of liver and kidney function, and discharge. Some quick slides from the VA ECMO. Here you can see where we puncture to the right femoral vein and the left femoral artery, and the here you can see the vein cannula and the distal perfusion with this technique here to have a perfusion to the left limb. So here you can see the implantation in the left image. You can see the implantation of the vein cannula, and here, while the arterial cannula is somewhere here. Here you can see the vein cannula, and some images about the intra-aortic balloon and the VA ECMO, about the LV pressure and volume, and one slide for the cost. This system with the pump, the oxygenator, the cannula, and the art cannula and the vein cannula, it's about less than 2,000 euros, while the impale is about 4,000 euros. Here you can see the post-procedural echo and the discharge. You can see here that we have a better left injection fraction. And yesterday we performed an echo assessment in this patient about 1 month from the procedure. No LVT obstruction, no residual MR. So this is our heart team, this is our thoughts for the heart team, and I would like to thank you.
Congratulations, Dr. Kosmas, for the management and the very nice result. I don't know if there are any other comments. And
maybe Dr. Lodiadis can make a comment about the ECMO. So we discussed, we anticipated this afterload mismatch, and maybe Theo and Kostas, you can make a comment as well. Do you see often this afterload mismatch? Do you implant the ECMO? Or do an impella, whatever?
Well, this is what I wanted to ask you. I mean, what was the reason for this collapse? It's still not very clear to me. So it was not LVOT obstruction. It was not para-ring regurgitation. It was not a left to right shunt, right? A huge shunt. Did you close the septum, by the way?
No, it was not significant.
So if you exclude all this, if you exclude embolism or whatever else, so you concluded, I suppose, that was just the mismatch.
I think it was an afterload mismatch. Yeah. And I don't know, Theo, do you experience like that, something like that?
If you didn't do right heart catheterization before the case, really there is no clear reason for this, but in the right heart catheterization, pulmonary vascular resistance were 5, and left ventricular diastolic pressure is very, very high, and this patient had a combined post and precapillary and postcapillary pulmonary hypertension. So when you open the mitral valve, in some cases, acute decompensation can occur in that kind of cases. For the AST, if there is no oxygen desaturation, for this case, it is better that the AST was opened because of the decreased left atrial pressure. But so this is why I always underline that catheterization is very, very important in that kind of cases. So the reason for the acute decompensation is you put a mitral valve, well-opening mitral valve, and the mismatch occurs, and then you put the ECMO and decrease the pulmonary pressures and pulmonary vascular resistance, and then patient recovered. I think so.
That's excellent.
The reason for the collapse is, I think, the reason for the collapse is what Dr. Stavridis said and I said at the beginning, because when you have such a poor contracting ventricle, the best would be to have edge-to-edge and have a 1+ or a mild residual mitral regurgitation. Now, this, you abruptly abolish all the mitral regurgitation. And once then, the anesthesiologist told us that he's going very high on inotropes and vasopressors. The next thing would be to put the balloon pump. And 3-4 hours later, even though this didn't help, the balloon pump and the drug didn't help, so the next step would be to put the VA ECMO. And the reason we didn't put an impella is that we don't have the system at our hospital due to cost reasons. So we went to the cheaper solution, which is the VA ECMO.
So, Vangeli, you placed the ECMO. How easy is to do it percutaneously? You think it's something that can be incorporated in everyday practice in patients with cardiogenic shock?
We placed it with Dr. Stavridis at 3 o'clock in the morning with a Seldinger technique. We put the 22 French cannula. We punctured the vessels with echo. We put the venous cannula. The arterial cannula, 17 French, the arterial cannula, 22 French, the venous cannula. Then it takes 22 minutes to prime the whole system, and then Dr. Stavridis was there. We de-aired the system, and it started functioning. Gave to the patient 6 liters of flow. This is right, Dr. Stavridis. Needed it?
A comment, Dr. Stavridis, also.
I'm here to emphasize that you don't need a cardiac surgeon to do these things. You can do it. You are very competent. Most of you are very seasoned interventional cardiologists. For you to use some catheters guided with ultrasound and being in the ideal place for placing an ECMO in the cath lab, it's just a piece of cake for you. The only thing is you need a perfusionist. You don't need a surgeon, and Dr. Leon, the others proved that. And the most importantly is when you put an ECMO, sometimes you forget to secure a distal perfusion of the leg by just using a catheter, which again, it was not with a cut down, was under ultrasound, just to perfuse the superficial femoral artery. And it was a timely procedure, and the fact that I don't know whether the impella would have helped this guy, because I think that his right ventricle was not good either. So probably we'll end up in other places do an impella, which costs, as you saw, it's 40,000 euros, and then you had to put maybe an ECMO. So we'll have an ECPella, how do they call that? But it was, I want to congratulate you on that. It's from now on, that's the way to do it. No surgeons, you can do it excellent, much better than the surgeons with the cut down.
No, but on the other hand, 3 a.m. it's a surgical hour. And maybe Dr. Patakos can verify that, right? 3 a.m. it's where the surgeons should help, desperate interventional cardiologists.
Would you prefer the impella if you had it available? I think it is easier than the ECMO.
Well, yes, but in this situation, I don't think so. I think I have to agree with Dr. Stavridis' comments. So the situation, I think it was the proper indication of ECMO. By the way, I saw yesterday in the outpatient clinic this patient. He went to the 7th floor of Onassis Hospital with no stop. So, of course, he's a young patient. Still, his LV is not optimal, but he doesn't have any dyspnea whatsoever. So I thank all the heart team for that and for the presentation.
Thank you.
We thank you all from the Onassis Cardiac Surgery for this nice case and showing all the aspects and the successful collaboration between interventional cardiologists and surgeons. And now we're moving to the